All right, folks, today we are covering two topics. We're covering anaphylaxis, so a severe allergic reaction, and drug overdoses. Let's get started. So prior to about 2004, 2005, there was no consensus definition for what anaphylaxis actually is. There were varying opinions on what the diagnosis was, and so it was very hard for us to kind of get a determination of the epidemiology and who is and who isn't having anaphylactic shock, who is and isn't in anaphylaxis. So in 2004 and 5, experts came together and they made a consensus statement, and they agreed upon a specific definition of anaphylaxis, which is a serious allergic reaction that is rapid in onset and may cause death. There are varying symptoms and signs, different signs and symptoms for anaphylaxis. The traditional ones that we think of are hives, trouble breathing, wheezing, and for all of these, for patients who have or are having a severe allergic reaction, we need to provide them immediate treatment. And so the best kind of immediate treatment that we can give is using an epinephrine autoinjector that will allow the blood vessels to dilate, return to normal, allow relax the musculature in and around your neck so you're not constricting your esophagus. Now restricting your breathing, and currently on the market there are four major different types of epinephrine autoinjectors. So you have your very traditional EpiPen, you have a generic derivation of the EpiPen, you have an even more generic autoinjector, and then you have kind of the newest one out here is these AviQ autoinjectors. And each of them have a little bit different administration. With the epinephrine autoinjectors, when pass these around, you may see that on some of them, the time to keep them in place into a person, it might say 10 seconds, and there are other ones that are more current that say 3 seconds. No, those are trainers. I'm not giving you live epinephrine autoinjectors. And so, with starting off with an EpiPen name brand. With the name brand EpiPen, they have updated it so that currently there's a couple of steps, but they're relatively simple. So if you have the trainer right here with you, a good saying that I like is blue to the sky, orange to the thigh. So you remove that blue cap, pull off the safety release, you hold the leg still, place the orange end against the outer mid-thigh, swing and push down hard until you hear a click, hold it for 3 seconds, and then you can remove it. it automatically, once you remove the EpiPen, it automatically encloses the needle in a protective plastic covering so that you don't stab yourself, which is quite nice. And then we also have the newer AviQ ones. And these ones are a little bit different because they're shaped differently, and also they talk to you. So when I pull this out,
no needle or drug and is for training purposes only. Do not use this trainer during an allergic emergency.
we pull off the red tab.
Place black end against outer thigh. Then push firmly and 2, 1. Training complete.
So they have done research comparing the AviQ versus epinephrine autoinjectors, and there is about a 20% difference in the success rate of administration with an AviQ versus with an epinephrine autoinjector. Mainly because you have verbal prompts prompting you on exactly what to do, because sometimes people forget in the heat of the moment when there's an emergency. And then finally, we have the most generic one, the ones that you may see around campus. These are called Adrenaclix. These are the generic of the generic. They're also the cheapest. And with these ones, this is a live one, so we're not actually going to use it. These don't come with trainers. You can see they have 2 blue tabs on both sides, and you have to pull both of them off, and you can see just a little red end, and you have to hold this one in for 10 seconds versus the 2 seconds and 3 seconds for the EpiPen and the AviQ. All right, so now what I want everyone to do is, I'll even let out the AviQ trainer. I want everyone to practice once or twice with either the epinephrine autoinjector or the AviQ. All right?
What's the difference between like what's in that? I know it's not. I'm also sorry, but I made that.
Does it make a difference?
It's not a life-threatening allergy. All right. Yep. So anaphylaxis is different than just like an allergic reaction because it's that rapid onset and it's that life-threatening. And so hopefully all of you have practiced at least once or twice now. You can use an epinephrine auto-injector through clothes, and sometimes there are different doses of auto-injectors. You can see there's two different dosages, so let's go back here. If you look very closely on this, you can see a dosage of 0.15 milligrams and 0.3 milligrams. It's just based upon patient's weight. And so if you have a pediatric patient, all right, so here's another 0.3. If you have a pediatric patient or anyone under 66 pounds, you're going to give them the 0.15. Those are typically on campus going to be found more in our lower school versus everywhere else we're going to have the 0.3 dosage. All right. Any questions on epinephrine auto-injectors? All right. Short one. It kind of dovetails, I thought, nicely into also drug overdoses. So in the U.S., I would hope you all are aware of our drug overdose problem, specifically with prescription drugs. We can see through some epidemiology that all drug overdoses have been rising over time, pretty at a steady rate between when the federal government started recording in like the late 90s, early 2000s, all the way to about 2015. And then we see this really rapid spike starting in 2015. And that really rapid spike can be explained by the different waves of opiates and opiate overdoses that have occurred. So kind of the first wave we have here is the prescription opioids. That kind of comes into play starts in the 90s and early 2000s. And then by about 2010, we start seeing more of a heroin problem in the United States. And then by about the third wave here, by about 2015, 2014, we get into the synthetic opiates. So that's our fentanyl, our carfentanil, really devastating and driving that overdose into overdrive. And you can see here some lethal doses of heroin, fentanyl, and carfentanil. A lethal dose of heroin is about 30 milligrams. Fentanyl, it's about 3 milligrams. And carfentanil is anywhere from 0.3 to 0.3 milligrams. So we're essentially 10xing to 100xing the lethal doses. There isn't as much carfentanil out there as there is fentanyl, and there is another drug that is being mixed into heroin that we'll get into in the end that's also driving and making difficult the efforts to help save people's lives. So first, let's start with some signs and symptoms of overdosing. We have slow and shallow breathing, typically less than one breath every 6 seconds, gasping breaths, maybe a blue skin tone, typically unresponsive. They don't have a response typically to pain, and they will have small pupils, almost pinpoint pupils, kind of like this picture shows us here. So when a person is in an overdose, here's kind of the progression of which they will go through first. They will ingest that excess heroin or opioid. Then their breathing starts to slow. They lose consciousness. Then that slowing of breathing and heart rate deprives the heart, brain, other vital organs of oxygen. Then we start to have brain damage, right? So if we think about for a cardiac arrest, for every minute a person does not have effective CPR and AED, their chances of survival goes down by about 10%. An opioid overdose, is a breathing emergency. And so in order to save someone's life, typically we have to breathe for them. And so if we get down to enough, we start to have cardiac arrest. And if a patient is out for longer than about 10 minutes, it's very likely that they will not survive. However, when we try to respond to these emergencies, the critical first step is recognizing it, checking for a pulse, and beginning CPR. Then we're notifying medical providers. We're administering naloxone, or Narcan as it's called, the brand name. We're doing rescue breathing, and if we have successfully got them to wake up and start breathing on their own, placing them in the recovery position because they might throw up on you, and then providing care until EMS arrives. Sometimes EMS can take up to, in excess of 45 minutes to an hour to arrive, particularly in rural areas. I'll give you an example of when I was in undergrad. I was working at Middlebury College in Middlebury, Vermont, central Vermont. We were covering a basketball game, and we had someone who needed to get transported to the hospital, and they were in the lobby. The hospital is from that location probably about a mile down the road. We had to wait 45 minutes for an ambulance from the other side of the state to arrive. So, and sometimes even in urban areas like Phoenix, you might have to wait 10, 15 minutes. And so you might have to provide that care for an extended period of time. So let's talk about how it actually occurs at a 10,000 foot view at the kind of molecular level. You have opioid receptors in your brain, much like you have other pain receptors and the such. Opioids, so fentanyl, carfentanil, heroin, will bind to these opioid receptors. And then what we're trying to do with administering naloxone or Narcan is it can kick out those opioid, quote unquote, molecules out of those receptors, but it will only last for kind of a brief period of time. We're talking like 10, 15 minutes. And so not only is it critical that we administer naloxone, it is also critical that we perform rescue breathing and potentially CPR in order to save someone's life. There have been cases where people have suspected an overdose. They have just administered naloxone and then they have not done anything else. It's good that they administered naloxone, but you still need to try and breathe for that person. Here is what a spray nozzle of naloxone or Narcan looks like. Fortunately, the FDA in March approved over-the-counter sales of naloxone. And actually this week, you should, probably more like early next week, you should be able to buy Narcan over the counter. So you could walk into any CVS in Walgreens and buy a 2-pack of Narcan for like $50, which is great. So these are the instructions that they come with Narcan. We are trying to see if they are alert. We are checking for those signs of an opioid overdose, so they're not waking up, not breathing they're breathing very slow or irregularly, and the pupils are almost pinpoint. You're removing the Narcan spray from the box. We're holding it like a little syringe right there. We insert the tip into the patient's nose, press firmly, and remove the spray. It's a one-time use per spray. Then this should also say, reevaluate, but this is for lay people. Emergency medical help, move them onto their side so that if they do wake up and they start vomiting, they won't choke on their own vomit. Watch the person. If they don't respond, you can administer another dose as well. And so there isn't just intranasal delivery of naloxone. There is also intramuscular. And so what you have to do then, if you are like me and you have intramuscular naloxone, is you have to take your vial of naloxone, draw up about 2 milliliters of naloxone and inject it into their thigh, much like we do with epinephrine auto-injectors. Same idea, same concept, except I'm just drawing it from a vial and into a syringe and putting it into their thigh. And so there are a handful of withdrawal symptoms from Narcan naloxone: body aches, runny nose, weakness, restlessness, diarrhea, vomiting, abdominal cramps, and then increased heart rate and blood pressure as well. And so then finally, there is one drug that is currently being mixed with heroin that is essentially fatal for some patients, or it's called xylazine. It is a horse tranquilizer. The bad thing about xylazine is that Narcan doesn't work to reverse an overdose. If a patient has injected heroin mixed with xylazine in it, it's relatively ineffective. So some things that harm reduction is trying to do is distribute xylazine test strips to people who are using heroin and allowing them to test if the drugs that they are taking contain xylazine. Unfortunately, in order to try and combat the drug dealers, some states have made it illegal and unintentionally made the carrying test strips for xylazine illegal. Because it is drug paraphernalia. And so that makes it a lot more difficult in order for us to potentially address this next wave of overdoses and overdosing if we start making carrying xylazine test strips or fentanyl test strips illegal. What's up, Jake?
Why is it that Narcan doesn't work?
It's just a different receptor, and it's a different mechanism through which xylazine attaches to the brain through a different receptor. And so, Narcan. It attaches to one specific one that also fentanyl, carfentanil, and heroin attached to, but not necessarily xylazine. The other thing is, since it's a tranquilizer, right, we're going to suppress your parasympathetic system. You're going to suppress your breathing. You're going to suppress your heart rate. Once again, also very dangerous. And then for patients who constantly use or consistently use drugs with xylazine in them, they typically will develop wounds that don't heal around the injection site. So it will be very difficult for these wounds to heal, and patients will oftentimes have to have bandages applied several, if not dozens of times in order to help them heal from these wounds. So their skin can become like black and necrose and die. Yeah, it's really a great time. Any questions on drug overdoses? All right. We blazed through that, as I thought. Let's see, 30. Let's take 5, and we'll come back and I'll find something for us to do, eh?